Usually when we talk about a medical diagnosis, there's this, expectation of precision.
Oh, for sure.
It's like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is.
Right. Broken or not broken.
Exactly. It's clean, it's visible, and honestly, it's kind of comforting.
It is. I mean, we are wired to want binary answers. We want to see the problem right there on a screen so we can apply the exact right tool to fix it.
But then you step into the world of pelvic health, and suddenly that x-ray machine is, it's basically useless.
Yeah, completely.
We're looking at a diagnostic landscape that is incredibly murky. And if you've ever felt a sudden leak when you sneeze or like a heavy bulge when you stand up, you know exactly how isolating this feels.
It's incredibly isolating for patients.
But the data shows you are surrounded by millions dealing with the exact same failure of their internal anatomy. So today, we're bringing together a massive stack of sources for this deep dive to look at pelvic floor dysfunction.
And it's a really comprehensive stack.
Yeah, we've got clinical guidelines from NICE and the British Society of Urogynecology, systematic reviews, and the absolute latest physiological research.
Including some really groundbreaking findings from Agencia, FIPESP, and Toro Scholar.
Right. And it's a remarkable collection of data because it fundamentally challenges how the medical community has historically treated this region of the body, doesn't it?
It really does. We're looking at a massive paradigm shift in understanding the sheer physical and, well, chemical forces at play here.
Exactly. And our mission today is to uncover exactly how body weight impacts pelvic health. But we're driving toward one highly specific, critical question that you might be agonizing over if you or someone you know is facing this.
Which is a huge concern for a lot of people.
It really is. The question is, can weight gain after treatment actually affect your results? Okay, let's unpack this right out of the gate.
Let's do it.
Before we can understand how a surgical or medical treatment might fail, we have to look at the baseline physics, right? Like, we need to understand how the pelvic floor gets damaged in the first place.
Yeah, so to grasp what is happening here, you have to understand the concept of intra-abdominal pressure, or IAP.
Okay, IAP.
Right. I want you to visualize your abdominal cavity as a pressurized, sealed canister.
Like a literal metal canister.
Yeah, exactly. And the top lid of this canister is your diaphragm, the muscle you use to breathe.
Okay, makes sense.
The rigid sides are your abdominal and back muscles, and the bottom lid, the base supporting the entire weight of all your internal organs, is your pelvic floor.
So it's the ultimate support system, just like resisting the downward force of everything inside us, plus gravity.
Precisely. Just by standing upright, you're exerting a static resting pressure on that bottom lid.
But I'm guessing that pressure isn't always static.
Not at all. Every time you take a deep breath or cough, laugh, or, lift a heavy box, you're altering the volume and shape of that cavity.
So it squishes the canister.
Right. When you contract your abdominal muscles, they generate this intense inward and downward force, and that force has to go somewhere.
And it hits the bottom lid.
Yes. It's resisted by the diaphragm above and the pelvic floor below, which creates a massive spike in intra-abdominal pressure.
Wow. I like to picture the pelvic floor as like a complex suspension bridge or maybe a reinforced hammock holding up incredibly heavy cargo.
That's a great visual.
Because if you constantly overload that hammock with excess weight, it makes complete sense that the ropes, which in our bodies would be the connective tissues, ligaments, and muscle fibers, they don't just stretch like a rubber band.
Yeah, they don't bounce back.
Right. Over time, under constant heavy load, they begin to physically fray.
That analogy is highly accurate, especially when we look at the clinical data on obesity. The sheer mechanical load of excess adipose tissue creates a constant, unyielding strain on those structural ropes.
So the hammock is just constantly bearing too much weight.
Exactly. The muscles become chronically fatigued, they lose their elastic recoil, and the numbers we're seeing in the research are, honestly, they're staggering.
Give me some numbers.
Well, an increase of just 5 units in a person's body mass index, or BMI, can elevate the risk of urinary leakage by 20 to 70%.
Wait. Just 5 BMI units?
Just 5.
Depending on your height, that could literally just be 20 or 30 pounds. I mean, that is not a massive, unrecognizable amount of weight.
It's really not. But in the enclosed physics of that pressurized canister, it's a devastating burden.
Wow.
Yeah. When you move into the category of clinical obesity, The data shows it increases the likelihood of stress urinary incontinence, which is that sudden leakage that happens when you exert physical effort, like coughing or jumping by 4 to 5 times.
4 to 5 times. That means a huge portion of the population is walking around with this immense mechanical stress just slowly tearing away at their pelvic hammock.
Exactly.
And the sources point out it's not just body weight causing this pressure, right?
Absolutely not. The physics of IAP apply to any chronic downward force.
Like what?
A chronic smoker's cough, for example, or heavy lifting at a physical job, or even chronic constipation where you're repeatedly bearing down. And pregnancy is another massive factor. You have the weight of the growing fetus, the amniotic fluid, and then the extreme mechanical trauma of pushing during labor. All of this contributes to that structural fraying. If we connect this to the bigger picture.
It's not just a little bit of leaking when you sneeze. I mean, we're talking about total structural collapse.
Right. This mechanical wear and tear leads directly to a condition called pelvic organ prolapse, or POP.
And that's when things actually drop, right?
Yes. This is where the hammock fails to such a severe degree that the organs it's supposed to hold up, the bladder, the uterus, the bowel, actually drop out of their natural position.
God, that sounds awful.
They press against the vaginal wall, creating a heavy bulge. And in severe cases, those organs can literally protrude outside the body.
Which sounds incredibly distressing. So we firmly established that weight acts as this physical burden, a purely mechanical force pushing down on the bridge.
Correct.
But as I was reading through the FAPESP research, I hit a plot twist that honestly blew my mind.
The metabolic component.
Yes. The research reveals that fat isn't just a heavy, inert weight sitting in your body. It is an active chemical saboteur.
This is where our understanding of body fat and pelvic health has completely evolved over the last few years.
Because before, they just thought of it as weight, right?
Exactly. Historically, the medical community viewed fat strictly through that mechanical lens we just discussed. The heavier the cargo, the more pressure on the hammock.
Right.
But researchers are now focusing intensely on something called the Visceral Adiposity Index, or VAI.
Let's break that down for a second. Visceral fat is the fat that wraps around your internal organs deep inside the belly, correct?
Yes, deep inside.
So it's not the subcutaneous fat, which is the softer fat that sits right underneath the skin that you can, pinch.
That's right. And the Visceral Adiposity Index isn't just a measurement of how big your waist is, it's a complex formula.
What goes into it?
It combines your waist circumference and BMI with your blood work, specifically your triglycerides and HDL cholesterol.
Oh, wow. So it's a chemical snapshot, too.
Exactly. It gives doctors a mathematical model of how your fat is actually functioning. It tells them if your fat is metabolically active.
And the results were crazy.
Yeah, a major study out of Agencia FAPESP revealed that the presence of high visceral fat increases the likelihood of stress urinary incontinence by a staggering 51%.
And what's wild to me is that the researchers originally assumed that gynecological fat, the fat that sits closer to the hips, thighs, and the pelvic region itself, would be the main culprit.
Which is a logical assumption.
Yeah, you would think the fat closest to the pelvic floor would cause the most damage just because of physical proximity.
Yeah.
But it turned out the visceral fat higher up in the abdominal cavity was far worse.
Which proves this isn't just about localized weight. Visceral fat acts almost like a rogue endocrine organ.
A rogue organ. That is so creepy.
It really is. It actively secretes pro-inflammatory substances, known as adipokines, into your bloodstream. And these chemicals circulate throughout your entire body, creating a state of low-grade chronic inflammation.
Wait, so you're telling me that fat isn't just sitting there being heavy? It is actively functioning like a rogue organ, chemically attacking and weakening the pelvic muscles from the inside.
I am. That low-grade chronic inflammation directly compromises muscle quality on a cellular level.
So it's breaking down the muscle.
Yes. It degrades the contractile proteins in the muscle fibers, which reduces the pelvic floor's ability to quickly flex and hold tension when you cough or jump.
Okay, that's bad enough.
But the biological sabotage gets even more insidious. Studies have shown that adipocytes, the actual fat cells themselves, can deposit directly into the fibroblasts of the transverse urethral muscle.
Okay, let's translate that because that sounds terrifying.
It is a bit scary.
The transverse urethral muscle is essentially the sphincter, the physical clamp that pinches the urethra shut so you don't leak, right?
Correct.
And fibroblasts are the cellular builders, the microscopic scaffolding that builds the connective tissue.
Exactly. So imagine the builders of your structural scaffolding are being hijacked and replaced by fat cells.
Oh my God.
The muscle literally loses its structural integrity from the inside out. You are facing a devastating dual attack.
Mechanical and chemical.
Yes. Mechanically, the extra weight is pushing down and tearing the bridge cables. Metabolically, the visceral fat is sending out chemical signals that inflame and rot those exact same cables while physically replacing the steel with soft fat.
It's a complete structural failure.
What's fascinating here is how this dual attack sets the stage for major treatment challenges.
Which brings us perfectly to the core mission of our deep dive today. Knowing that weight attacks the pelvic floor both mechanically and metabolically, we arrive at the million-dollar question.
The big one.
Right. What happens if a patient undergoes surgery or medical treatment to fix their pelvic floor, but their weight fluctuates or increases after the fact? Can weight gain after treatment affect the results?
The data on this is incredibly sobering, and it is vital information for you to understand if you're weighing your treatment options.
Because surgery isn't always a permanent fix, is it?
No, it's not. We have a comprehensive meta-analysis from Toro Scholar that looked at 31 peer-reviewed articles.
And a meta-analysis is basically a study of studies, right? They
Yeah.
pool the data from thousands of patients.
Exactly, to specifically examine post-treatment outcomes for overweight individuals.
And the numbers are crystal clear.
They are undeniably clear. The meta-analysis shows that obesity defined as a BMI of 30 or higher is associated with an increased odds ratio of 1.38 for objective prolapse recurrence after vaginal repair.
Okay, let me pause you there.
Sure.
Let's explain objective prolapse recurrence for a second. That doesn't just mean a patient comes in saying, hey, doc, I feel a little heavy down there.
No, subjective feeling is different.
Right. Objective recurrence means the doctor does a physical exam, takes imaging, and clinically verifies that the organs have actually dropped again. The surgery physically failed.
Yes. And it's an odds ratio of 1.31 after any surgical approach. An odds ratio over 1 means the event is significantly more likely to happen compared to the control group. So an obese patient is substantially more likely to have the prolapse anatomically return, requiring more intervention.
Which means more surgery.
Right. And it's not just about the prolapse returning, it's about severe traumatic complications from the surgery itself.
Like what?
The Toro Scholar study found that severe obesity increases the odds of surgical complications, specifically mesh exposure, with an odds ratio of 2.10.
Mesh exposure. That means a patient is more than twice as likely to experience a situation where the synthetic surgical mesh used to act as a new hammock actually erodes and cuts its way through the vaginal wall.
Yes. It is incredibly painful, it can cause chronic infection, and it requires complex revision surgery to remove the mesh and try to fix the damage.
That is horrifying.
It is. Even if we zoom out from those severe complications, the general statistics from the British Society of Urogynecology are pretty stark.
What do they say?
They note that 25 to 30 out of every 100 women who have surgery for prolapse will develop another prolapse in the future.
Almost a third of patients.
Yes, and they state definitively that this risk is astronomically higher in overweight individuals.
I mean, it makes sense. You can have a world-class surgeon go in, lift the organs, and stitch everything back into place.
A perfect surgical repair.
Right, but if the surrounding vaginal tissue is still structurally weak because it is still bathing in that inflammatory soup of adipokines, it can't hold the sutures.
The tissue is friable. It simply cannot hold the stitches or the mesh over the long term when you immediately reapply that massive intra-abdominal pressure.
And this isn't just about surgical failures either. The sources show that even non-surgical treatments, like prescription medications, are undermined by weight.
Yes, absolutely.
There's a medication called duloxetine, which is sometimes used off-label to treat stress urinary incontinence.
Right. Duloxetine works on the central nervous system. It increases the levels of serotonin and norepinephrine, which theoretically stimulates the pudendal nerve, causing the sphincter muscle around the urethra to contract more strongly.
Here's where it gets really interesting. The data shows this drug is notably less effective in overweight patients. Why is that? Is the fat just, like, absorbing the medication?
It's a combination of factors. Yes, pharmacological distribution is altered by high body fat, meaning the drug might not concentrate as effectively in the bloodstream where it's needed.
Okay, so it gets diluted.
Partly, yeah, but primarily it's a physics problem.
How so?
Well, duloxetine might give that sphincter muscle a 20% boost in resting tone. But if a cough generates a downward mechanical force from a high BMI that requires a 50% stronger clamp to stop a leak, the drug's chemical boost is instantly overpowered.
Wow, overpowered by the sheer physical mass pressing down on it.
Exactly, the physics win every time.
So does that mean if you gain weight after a successful surgery or while on a treatment protocol, you are essentially undoing the doctor's work because you're reapplying that mechanical and chemical stress?
That is exactly what it means. You are putting a fresh surgical repair under an immense unnatural load.
So the surgery alone isn't enough.
Not at all. Lifestyle and weight management must be considered primary medical treatments that go hand in hand with surgical intervention.
They're a package deal.
Yes. Without addressing the underlying environment of the body, the recurrence of symptoms or the failure of the surgery entirely isn't just possible, it is the expected outcome.
It's like spending millions of dollars to string brand new steel cables on our suspension bridge, but then driving 10 overloaded semi-trucks over it the very next day.
Exactly.
Those new cables are going to snap just like the old ones did. So if surgery has such high risks of recurrence and complication without lifestyle intervention, what can you do?
There are excellent conservative options.
Right, how can you protect yourself or improve your outcomes before deciding to go under the knife?
This is actually the most empowering part of the clinical guidelines. Because while the risks of ignoring the root cause are severe, the capacity for reversing this trend through conservative care is incredibly well documented.
Okay, lay it on me.
The two unshakable pillars of this are weight loss and highly specific physical therapy.
Let's talk about the weight loss first, because the numbers here are actually very encouraging. The listener might be thinking, oh, great, I need to lose 50 pounds before my pelvic floor works again.
I know that's what everyone assumes.
But the data says something completely different.
It absolutely does. The clinical guidelines from NICE show that losing just 5 to 10% of your body weight can have a profound structural impact.
Wait, really? Just 5%?
Yes. One major study noted that a 5% weight loss can result in a massive 50% decrease in stress urinary incontinence episodes.
That is phenomenal.
And it is associated with a 73% reduction in overactive bladder symptoms.
Okay, let's do the math on that. A 5% weight loss for someone who weighs 200 pounds is just 10 pounds. Dropping 10 pounds can literally cut your daily leakage episodes in half.
Because you are simultaneously relieving the mechanical pressure inside the canister and reducing the volume of metabolically active visceral fat.
So you're turning down the dial on that chronic inflammation.
Exactly. You're attacking both sides of the problem. But weight loss is only half of the conservative care equation.
Right, the physical therapy.
Yes, pelvic floor physical therapy, which the clinical guidelines universally consider the gold standard of first-line treatment.
But the sources give a massive warning here, right? You can't just go rogue, read an article online, and start doing Kegels while you're sitting at stoplights. Professional supervision is an absolute requirement.
This cannot be overstated. According to the research, roughly 30% of women cannot correctly contract their pelvic floor muscles on their own without guidance.
30%. That's almost a third of patients completely failing to isolate the right muscle.
And it's significantly worse than just failing to isolate it. Many individuals perform the exact opposite biological movement.
How do you do the opposite?
Well, instead of lifting and drawing the pelvic floor up and in like pulling the hammock tight, they actually bear down, pushing the muscles outward.
Oh, wow.
Yes, so if you have a weakened pelvic floor or developing prolapse, and you're repeatedly pushing down on it while thinking you're doing a Kegel, you are actively accelerating your own prolapse.
It's exactly like going to the gym to do bicep curls, but you're accidentally doing a reverse triceps extension with terrible form.
That's a perfect way to put it.
You aren't just failing to build the muscle you want, you're actively tearing a tendon and injuring yourself.
This raises an important question, right? How do we ensure patients are actually retraining their muscles rather than harming them?
What's the solution?
The consensus across the BSU and FASK sources is that patients need a referral to a specialized pelvic floor physical therapist who utilizes biofeedback.
Let's explain biofeedback because it sounds like sci-fi, but it's actually incredibly practical.
It is entirely practical. A therapist uses external sensors, or sometimes a small vaginal or anal probe that connects to a monitor.
Okay, so you can see what's happening.
Exactly. When you attempt to contract your pelvic floor, you can look at the screen and see a graph spike if you're doing it right. If you bear down incorrectly, the graph drops.
Brilliant.
It rebuilds the neuromuscular pathway, the connection between your brain's motor cortex and the specific muscle fibers. It proves to your brain what the correct movement actually feels like.
And the timeline for this neuromuscular rebuilding is clearly defined in the data, isn't it?
Yes, it is.
The HAPSP researchers noted that with proper biofeedback guidance, Significant clinical improvement takes about 3 months of dedicated practice.
3 months to rebuild the pathways and strengthen the fibers, but the strict caveat here is that this strength must be maintained for life.
It's not a one-and-done thing.
Not at all. The pelvic floor is a striated muscle group, just like your quads or your biceps. If you stop training it, atrophy sets in. You lose the strength.
So you can't just do physical therapy for one summer, pronounce yourself cured, and go back to old habits.
Right, you can't just fix the bridge and then fire the maintenance crew. You have to keep those cables taut for the rest of your life.
And you have to keep the cargo, load your body weight at a manageable level.
The physical environment of the body has to continually support the QOL.
So what does this all mean? If you're listening to this, the core message screaming out from all these clinical guidelines, systematic reviews, and physiological studies is this: pelvic floor dysfunction is a structural issue.
Not a moral failing.
Exactly, not a moral failing. But it is highly stigmatized. People are so embarrassed to talk about these symptoms, and it's incredibly overlooked. But the most important takeaway is that you do not have to live with it.
You really don't.
And you certainly shouldn't accept it as just a normal part of aging. It is entirely treatable. Taking control of your visceral weight, even just a 5 to 10% reduction, combined with seeking out guided professional physical therapy, are the absolute necessary first steps.
Because otherwise,
Right, surgery is an option. But as the data clearly shows, unless you address the underlying mechanical pressure and the chemical inflammation first, surgery might just be a painful temporary illusion.
you have to address the foundation before you rebuild the house.
Exactly. And speaking of rebuilding the foundation, I want to leave you with one final mind-bending detail from that FAPESP study.
Oh, this part is fascinating.
The researchers mentioned they are currently planning to use advanced MRIs in their next phase of investigation to clinically assess something called myostenosis.
Which brings us back to our bridge analogy. Myostenosis is the direct infiltration of fat into the muscle architecture.
Yeah.
It's as if the solid steel cables of the bridge are slowly, invisibly transmuting into soft, pliable rubber from the inside out.
Right, they're going to watch via MRI how fat literally consumes and replaces the muscle fibers. And it just leaves me pondering this. If our muscles, the very biological structures that give us strength, mobility, and continence, can slowly be replaced by fat from the inside out as we age and gain weight, well, how might that change the way we view fitness, diet, and aging entirely,
It changes everything.
far beyond just the pelvic floor? It reframes body composition not as a shallow aesthetic issue, but as a deep, fundamental structural integrity issue. Just something for you to think about the next time you hear someone dismiss body weight as just a meaningless number on a scale.